Alright, so the next topic that we're going to start is ankylosing spondylitis. It's a HLA-B27 associated spondyloarthropathies. Okay, typically presents in males where sex ratio 5 is to 1 for male, aged 20 to 30 years old. It has polygenic inheritance, and its HLA-B27 is often used in making diagnosis as it's positive in 90% in ankylosing spondylitis, 10% in normal patients. So what are the features for ankylosing spondylitis? It's a young man who presents with lower back pain and stiffness. That's like a classic sign. Stiffness is usually worse in morning and improves with activity. And the patient may experience pain at night, which improves on getting up. So there's pain at night, and it improves on getting up. So these are some small things which need to be addressed. Small signs are there for every patient, for every disease. So what are the clinical examinations that you see? In clinical examination, you see reduced lateral flexion and reduced forward flexion. It's called scope. There's a test called Scober's test. A line is drawn 10 centimeter above and 5 centimeter below the back dimples. It's called the dimples of Venus, and the distance between the two lines should increase by more than 5 centimeter when the patient bends as far forward as possible. So usually there's more than 5 centimeter increase in those two lines distance, but for a patient with ankylosing spondylitis there is reduced forward flexion, there's reduced chest expansion as well. So okay, decreased lateral flexion of the lumbar spine is one of the earliest sign of lateral flexion is laterally movement, earliest sign of ankylosing spondylitis. There tends to be loss of lumbar lordosis and accentuated thoracic kyphosis in patient with ankylosing spondylitis. And the associations of ankylosing spondylitis are the A's: the apical fibrosis, anterior uveitis, aortic agitation, Achilles tendonitis, AV node block, amyloidosis, and choroiderina syndrome. So all these A's are associated with ankylosing spondylitis. Okay, now the diagnosis for ankylosing spondylitis. We have already talked about the clinical examinations. So what are the diagnoses? How do we diagnose ankylosing spondylitis? Low back pain that starts before the age of 45 years for 3 months. Refer the person to the rheumatologist for spinal arthritis. Assessment if 4 or more of the following additional criteria are present. So low back pain in a person of age less than 45 years. Low back pain that started before the age of 35. This further increases the likelihood that back pain is due to spondyloarthritis compared with low back pain that started between 35 and 44. So the less the number of years, the more likely. Waking during the second half of the night because of symptoms. So at night it starts. Buttock pain, improvement with movement or within 48 hours of taking NSAIDs. First relative with spondyloarthritis, current or past arthritis, enthesitis, psoriasis. Okay, X-ray of the sacroiliac joint is the most useful investigation for diagnosis and monitoring. So this is very important. X-ray of sacroiliac joints. Okay, so but changes may not be seen for many years after the onset of symptoms. X-rays are often normal early in the disease, and later changes include. Firstly, like early in the disease, it may be normal, but later changes include sacroiliitis, subcondylar erosion, sclerosis, squaring of the lumbar vertebra, and bamboo spine. It's late and uncommon. Spirometry may show a restrictive defect due to a combination of pulmonary fibrosis, kyphosis, and ankylosis of costo vertebral joints. Management may be NSAIDs at lowest possible dose, biological DMARDs like adalimumab, certolizumab, picol, etanercept, golimumab, infliximab, secukinumab if the above fails. Physiotherapy. So these are very important. What's next? Psoriatic arthropathy. So correlates poorly with cutaneous psoriasis. You may think of the skin part, but it correlates poorly with cutaneous psoriasis and often precedes the development of skin lesions. So around 10% of people with skin lesions develop an arthropathy, with males and females being equally affected. So types will be like rheumatoid like polyarthritis, 30 to 40% most common type. Asymmetrical oligoarthritis typically affects hand and feet. Sacroiliitis, DIP joint disease, arthropathy, arthritis, mutilans, Severe deforming finger, telescoping fingers are called, treated as rheumatic arthritis but better prognosis. So all these things need to really keep in mind. Dactylitis describes an inflammation of a digit or finger or toe. Causes can include spondyloarthritis, psoriatic and reactive arthritis, sickle cell disease. Other rare causes include tuberculosis, sarcoid, and syphilis. All these can be causes of dactylitis. Next would be autoimmune connective tissue disease, very important as well for the exam. SLE. So in SLE, what do you look for? It's much more common in females, as we know from before, and more common in Afro, Caribbean, and Asian communities. Onset is usually 20 to 40 years old age. Incidence has risen substantially during the past 50 years. It's very much common in Asia as well. So pathophysiology, you see association with HLA-B8, DR2, DR3, all three are there. Thought to be caused by immune system dysregulation leading to immune system complex formation. So immune complex formation is mainly the pathophysiology. Immune complex deposition can affect any organ like skin, joint, kidneys, brain, most commonly affected. Skin, joint, kidney, and brain mostly affected. That's what we see for SLE. There's skin involvement, there's kidney and joint involvement as well. These are more highlighted rather than the brain involvement. Clinical features would be fatigue, headache, and poor concentration. So this is one of the features which may be ignored because of how non-specific they are: fatigue, headache, and poor concentration. Arthritis, one of the major features. Arthralgia is common, 90% of the patient, often associated with early morning stiffness. Tenosynovitis may also occur, but clinically apparent synovitis with joint swelling is rare. Joint erosion is not a feature for SLE. Severinus phenomena may be their skin, like several features are there, like photosensitivity, malor rash. This is the characteristic feature of SLE. Butterfly-shaped rash across the cheeks and nose with sparing of the nasolabial fold. Discoid rash characterized by hyperkeratosis and follicular plugging with scarring alopecia if it occurs on the scalp. Levator reticularis, which is also a feature of antiphospholipid syndrome. This was also there. It's also a skin feature. Lupus nephritis, that is the kidney being affected. For the heart, there might be pericarditis, which is common. Myocarditis and Liebman-Sachs endocarditis can also occur. Lungs, pleuritic pain or pleural effusion may also be a feature. Other features include pneumonitis, atelectasis, and pulmonary fibrosis. Let's see, cerebral lupus, interesting. Includes visual hallucination, something which we don't really, it's something not talked about that much in SLE, but visual hallucination might be cause might be a feature for cerebral lupus, as I was saying. So includes cerebral lupus includes visual hallucination, chorea, organic psychosis, transverse myelitis, lymphocytic meningitis, and seizures. Okay, all these can be there. Hematologically, neutropenia, lymphopenia, and thrombocytopenia, and hemolytic anemia. So pancytopenia can be a feature. Okay. Gastrointestinal features will be mouth ulcer may occur and may or may not be painful. Peritoneal serositis can cause acute pain. Mesenteric vasculitis, which can present with abdominal pain, and bowel infarction or perforation can also occur. Hepatitis is recognized though rare. Anti-ribonuclear protein, anti-RNP, it's like a marker for mixed connective tissue disease. Features of SLE as well. Systemic sclerosis and polymyositis can be interconnected as well. Okay, immunology for SLE is something very important. ANA is always positive. It's 99% sensitive, and 20% are rheumatoid factor positive. Now, anti-dsDNA is the one we're looking for. It's highly specific, 99%, more than 99%, but less sensitive. So anti-Smith antibody is the most specific, but anti-DSDNA is the one actually. Its sensitivity is also low. Antihistamine positive in drugs-induced lupus. Congenital less C4 is a predisposing factor for SLE. Okay, something which happens before the onset. Anti-Ro, anti-La antibodies may also be there. Antiphospholipid antibodies may also be there. So a lot of um, markers, immunological markers are there, but these are the ones to look out for. ANA, anti-DSDNA. In SLE, C3, C4 would be low, as they're saying here. Low levels of C4A and C4B have been shown to be associated with increased risk of developing systemic lupus erythematosus. Okay. CRP is characteristically normal or low, maybe increased in infection. ESR increases. C3, C4 low during active disease. Formation of complexes leads to consumption of complement. Less C4 is early marker for disease activity. Anti-DSDNA titers is the one used for disease monitoring disease activity, but not present in all patients. Anti-ROLA for neonatal lupus. This is so important. This comes in the exams all the time. Okay, moving to the next part, SLE and pregnancy. Unlike many autoimmune disease, SLE often becomes worse during pregnancy and the puerperium. Risks of maternal autoantibodies crossing placenta leads to condition termed neonatal lupus erythematosus. It's a very dangerous one, and neonatal complications include congenital heart block. It's strongly associated with anti-Ro antibodies. We've studied that a few minutes back. Anti-Ro antibodies very much a feature in neonatal lupus. Anti-Ro management would be British Society for Rheumatology 2018. Renal biopsy in case of renal involvement, proteinuria, hematuria, and cellular cast to know if it's like lupus or not. So the biopsy would be for lupus nephritis, and NSA for symptom control in mild non-renal lupus. Mild lupus prevent flare in all patients. So prevent damage steroid sparing like anti-malarial such as hydroxychloroquine or methotrexate. This can be given for mild lupus. Mild moderate lupus prevent flare like prednisolone, methylprednisolone can be started. Moderate lupus prevent flare stops steroid sparing azathioprine. Moderate to severe steroid sparing mycophenolate mofetil tacrolimus. This can be given as well. Refractory moderate severe lupus prevent flare and steroid sparing belimumab or rituximab. Refractory severe lupus IVIG and plasmapheresis. So all sorts of treatments are there for SLE. Refractory, the word here comes up again and again. It means like something which is not, it's like resistant already, unmanageable. So that's when you give IVIG plasmapheresis. Renal involvement in SLE, lupus nephritis OLN. Presentation can be fever, edema, hypertension, joint pain, myalgia, malar rash, foamy urine. Okay. Renal biopsy is the one where you can get to know about the disease, and treatment would be hypertension. Treat hypertension and give immunosuppressants like prednisolone, ibiprednisolone, methylprednisolone, cyclosporin, tacrolimus, or rituximab, azathioprine can be also given. Okay, drug-induced lupus. Not all the typical features of the SLE are seen here, with renal and nervous system involvement being unusual. Usually resolves on stopping the drug. So it's of course it's due to the drug that SLE lupus is happening. So what can be the features here? Arthralgia, myalgia, skin, malar rash, and pulmonary involvement. ANA positive in 100%, DSDNA negative since it's not from the body. Anti-Ro, anti-Smith positive in around 5%. And causes could be there's a mnemonic here P2CHIM like phenytoin, chlorpromazine, hydrolazine, isoniazid, minocycline, procainamide. WHO classification of lupus nephritis for part 2 is also there. Classification of the nephritis. There are 6 classes: minimal mesangial glomerulonephritis, mesangial proliferative lupus nephritis, Focal proliferative glomerulonephritis, diffuse proliferative nephritis, membranous nephritis, glomerulosclerosis. So we don't need to know the details in this for now. Okay, so for discoid lupus erythematosus, benign disorder generally seen in younger female. It's rarely progresses to SLE, and discoid lupus erythematosus is characterized by follicular keratin plugs and is thought to be autoimmune in etiology. So it's more like more cutaneous presentation. Features would be erythematous, raised rash, sometimes scaly, maybe photosensitive, more common on face, neck, ears, and scalp. Lesions heal with atrophy, scarring, and may cause scarring, alopecia, and pigmentation. Management would be topical steroid cream. Oral antimalarials may be used, second line hydroxychloroquine. Avoid sun exposure. Now, something called morphia. It's another disease. It's a form of localized scleroderma that may be circumscribed or generalized. In circumscribed morphia, there may be just one or two lesions with no generalized spread. So these lesions changes often begin with small violaceous or erythematous skin lesions, which enlarges and progresses to a firm, hidebound skin and variable degree of hypo or hyperpigmentation. Lesions eventually settle into a waxy, white appearance with subsequent atrophy here. Lesions vary in diameter between 1 to 10 cm. Conditions generally resolve within 3 to 5 years, although sometimes 25 years. Autoantibodies such as ANA are only positive in localized form of scleroderma, as against systemic subtypes when a positive ANA is one of the hallmarks of the disease. Okay, now we're coming to the other diseases that are there. Systemic sclerosis. Okay, it's a connective tissue disease. It's a condition of unknown etiology. Systemic sclerosis. It's a condition of unknown etiology is characterized by hardened sclerotic skin and other connective tissues. It's more common in females, 4:1. So there are three patterns of disease. Limited cutaneous systemic sclerosis. Raynaud's phenomenon may be the first sign. So scleroderma affects face and distal limbs, and associated with anti-centromere antibodies. CREST syndrome is a subtype of limited cutaneous systemic sclerosis. There will be calcinosis. CREST stands for calcinosis. That's calcium deposit in the skin. Raynaud's phenomena, as we know, esophageal dysmotility, sclerodactyly. That is, it's written here. Tight skin and ulcer in hand. Telangiectasia. Increased malabsorption can develop secondary to bacterial overgrowth of the sclerosed small intestine. So everything is sclerosed. This limited one. Unfortunately, pulmonary hypertension is one of the more common late complications in such patients. So it's very important. And for diffuse cutaneous systemic sclerosis, scleroderma affects trunk and proximal limbs predominantly. This was face and distal limb, trunk and proximal limb. Associated with SCL70 antibody, there was anti-centromere antibody. Hypertension, lung fibrosis, and renal involvement may be seen. Poor prognosis, hard skin. Okay, scleroderma without internal organ involvement. Just derma. Tightening and fibrosis of skin may be manifest as plaques, morphia or linear. So the antibodies that you see for systemic sclerosis is ANA positive in 90%, RF positive in 30%, and TSCL70 antibodies associated with diffuse cutaneous systemic sclerosis, as mentioned here, and anti-centromere antibody associated with limited cutaneous sclerosis, systemic sclerosis, as mentioned here. Management will be topical treatment for skin changes do not alter the disease course but may improve pain and ulceration. NSAIDs and limited benefits from steroids. So what do we give here? Okay, episodes of Raynaud's sometimes respond to nifedipine. Okay, calcium channel blocker or other calcium channel blocker. Dual endothelin receptor antagonist bosentan may be beneficial. Bosentan. Okay. Severe digital ulceration may respond to prostacyclin analog iloprost. The skin tightness may be treated systematically with methotrexate and cyclosporin. Scleroderma renal crisis benefits from ACE inhibitor to control BP and delay progression to CKD. Active alveolitis is often treated with pulses of cyclophosphamide, often together with a small dose of steroid. The benefit of this intervention is modest. Okay. Raynaud's phenomena. Now, Raynaud's phenomena is another thing which has been there for systemic sclerosis manifestation. So we need to understand what is it. It's maybe primary Raynaud's disease or secondary Raynaud's phenomena. So primary is what you call Raynaud's disease. It's typically present in young women. For primary one, 30-year-old with symmetrical attacks, both sides affected. The onset after 30-40 years, unilateral symptoms sometimes, rashes, presence of autoantibodies, digital ulcers, calcinosis, very rarely chilblains, itchy, uh, itchy painful purple swellings which occur on the fingers and toes after exposure to cold. They are occasionally associated with underlying connective tissue disease, but this is rare. Recurrent miscarriages can also occur. This indicates SLE or antiphospholipid syndrome. This is also these are very important diseases. Secondary cause, this is the primary cause. Secondary cause can be connective tissue disorders like scleroderma, that's what I've studied, rheumatoid arthritis, SLE with bilateral symptoms, leukemia, type 1 cryoglobulinemia, and cold agglutinins. Use of These are the secondary causes we are studying. Use of vibrating tools, drugs, oral contraceptive pill, ergot, cervical rib. Okay, management will be calcium channel blockers, nifedipine, or prostacyclin infusions. Okay, so next would be Sjogren's syndrome. It's also very important. Sjogren's syndrome is an autoimmune disorder affecting exocrine glands, resulting in dry mucosal surface. Maybe just remember dry. Sjogren's syndrome is it's dry. Everything is dry. So it may be primary or secondary due to rheumatoid arthritis or other connective tissue disorders, where it usually develops around 10 years after the initial onset. Sjogren's syndrome is much more common in females. There is a marked increased risk of lymphoid malignancy. The picture shows features. Okay, which picture? It's not here. Okay, so it's much more common in females. And what are the features? Okay, there's increases of lymphoid malignancy. Something you have to remember. Okay, features would be dry eyes, as I said, dry, everything is dry. Dry eyes, dry mouth, vaginal dryness, arthralgia, Raynaud's, myalgia, sensory point neuropathy, renal tubular acidosis, usually subclinical. Okay, so features we've already studied. What are the investigations? Rheumatoid factor positive in nearly 100% of patients, ANA positive in 70%. So these two are the ones we have to see. Anti-Ro, anti-La, antibodies in 70% of patients with PSS, primary Sjogren's syndrome, and antibodies in 30% of patients with PSS. Squamous test is filter paper near conjunctival sac to measure tear formation. Okay, you have to remember that it will be dry eyes in Sjogren's syndrome. Histology, focal lymphocytic infiltration. Lymphocytic infiltration mark increase in risk of lymphoid malignancy. It's something keeps on coming in the exams. Hypergammaglobulinemia, low C4. Management will be artificial saliva and tears. Pilocarpine may stimulate saliva production, so just make it wet. Okay, next would be relapsing polychondritis, important topic. This is a inflammatory condition, in fact, that involves cartilaginous structures, predominantly those of the pinna, nasal, septum, and larynx. So all the structure having cartilage will be affected. Male equals to female, can occur at any age, but mostly in the fifth decade. Symptoms depends on the area of the body affected. General symptoms include intermittent fever and weight loss, but other more specific features are sudden onset of ear pain with an inability to sleep on the affected side. So there's ear pain. Diminished hearing, monoarthritis, polyarthritis, back pain, myalgias, mild epistaxis, saddle-shaped nose, conjunctivitis, and episcleritis or scleritis. So eye involvement is there as well. Okay. Involvement of tracheobronchial cartilage. Wherever there's cartilage, there might be involvement. So leads to a hoarse voice, cough, stridor, or expiratory wheeze. Pulmonary functions test. including flow volume loops, should be performed. This is the degree of laryngotracheal disease. Since this is an important cause of mortality, no specific diagnostic laboratory findings in patients with RP, but the non-specific indicators of inflammation are often elevated. So, since there is inflammation, of course, the ASR/CRP will be elevated. So that's something which comes up again and again. Okay, so the management for relapsing polychondritis would be a mild disease usually responds to low dose glucocorticoids or NSAIDs. Tracheobronchial involvement require high dose glucocorticoids and immunosuppressants as described for SLE. Pseudoxanthomas elasticum is an inherited condition, usually autosomal recessive, characterized by an abnormality in elastic fibers. So there's an abnormality in elastic fibers. Pseudoxanthoma elasticum. Autosomal recessive disease, what are the features? Retinal angoid streaks, plucked chicken appearance, important. Small yellow papules on the neck, antecubital fossa and axilla. Cardiac, mitral valve prolapse, increased risk of IHD, gastrointestinal hemorrhage. There are reports of autosomal dominant inheritance in minority of cases. Okay, familial Mediterranean fever, also known as FMF. What happens here? Okay, there is a picture of Pseudoxanthoma elasticum here. FMF is known as recurrent polyserositis. It's an autosomal recessive disorder which typically presents by the second decade. 90% of 90% have their first attacks before the age of 18 years. It's more common in people of Turkish, Armenian, and Arabic region. So Arabic region people will have more of it. What are the features? Pyrexia, fever on and off. And what happens? Constipation, diarrhea may occur with or after the fever. Abdominal pain due to peritonitis. Many times, appendectomy scar is often seen due to multiple admission due to abdominal pain. Pleurisy, pericarditis, arthritis, nephrotic syndrome due to renal amyloidosis. It's erysipeloid rational lower limb, so it's difficult to actually diagnose this, but it's something which is important to know that it's from Arabic descent. Attacks are self-limiting and require analgesia. Colchicine may decrease the attack frequency. Okay, colchicine is something to look forward to. Next would be Behçet's disease.